I am now pleased to introduce our first speaker, Dr. John Balbus, the Interim Director of the new Office of Climate Change and Health Equity within the Office of the Assistant Secretary for Health. A physician and public health professional with over 25 years of experience working on the health implications of climate change, including roles in the federal government since 2009. We're so honored to have him with us today to share an update on the priorities of the new Office of Climate Change and Health Equity.
Great. Thank you so much, Catherine, and to the NIHCM team for holding this webinar and for the honor of being able to speak to all of you. It's really a delight to be able to share what's going on with our Office of Climate Change and Health Equity, and also to share this webinar with our wonderful panel. Can I have the first slide, please? So I've been asked to give a bit of an overview of the impacts of climate change on health, and I'm going to move that on to health systems as well, and think of it in terms of not just the people, but also the healthcare delivery systems that serve those people. I'm going to say a little bit and show actually some images to help convey why it's important to link health equity to climate change and what those linkages look like. And then lastly, I'll have the opportunity to describe our office a little bit and the role that we're trying to take in helping health systems prepare for climate change. Next slide, please. So this is a slide that I've borrowed from my colleague George Luber at the CDC that links up from that center ring the manifestations of climate change that we see physically, the rising temperatures, the increasing frequency and severity of weather extremes, the rising sea level, and the actual increase in carbon dioxide concentrations, which have their own impacts. And then the next ring is showing that there are many different ways that those primary changes in climate can impact our health. And I think as managers of health systems, as people who are caring for public health, the message here is that there are a lot of different things that we have to think about, and they operate on very different timescales. So some of the impacts of climate change are related to extremes and anomalies in weather, severe heat waves, extreme precipitation events that can lead to flooding, storms that stay over one area and lead to devastation from wind and flooding, and are really in the realm of emergency preparedness and disaster management. Whereas other kinds of manifestations of climate change, things like warmer winters than we used to have, earlier springs, changes in precipitation patterns on a seasonal basis, can change vector ecology or can change the productivity of agricultural systems and lead to much longer term kinds of changes in where we see certain kinds of vector-borne diseases. For example, the spread of Lyme disease northward up into Canada, or malaria and dengue climbing the slopes of the Himalayas because of warming temperatures there. And then lastly, there are a lot of impacts that are complex and societal in nature. And some of these are relate to the mental health impacts that populations experience, especially populations tied to the land, like Native Americans and First Nation folks in this hemisphere, who are witnessing, massive changes in their natural environments that change the way that they live and really have massive impacts on where they can live and their entire cultural well-being. All the way through to some of the things that we're seeing in different parts of the world, whether it's from inundation of low-lying habitat or the drying up of water supplies and forcing migration, that have really profound and existential kinds of threats to living in certain places. So again, a wide range of health impacts. That outer ring is a subset of the diseases that are affected. So from a clinical standpoint, there's a lot of different types of medicine, a lot of different practices, a lot of different types of facilities and systems that are impacted. Next slide, please. And what I want to convey is that while everybody is to some extent exposed to the changes in heat, to the extreme weather events, not everybody bears the same burden. And as we see with COVID, the people who are most at risk from climate change impacts are the people who are already saddled with health disparities and the burden of degradation of the basic social determinants of health, including both those that are related to economic opportunity, but also to the natural and built environments people who are living in urban heat islands, people who are living in neighborhoods where the infrastructure has not been maintained as well as others. And we'll see pictures of what this really looks like. But the point is that the social determinants of health that COVID has certainly brought to the fore as being something that all health systems need to be thinking about pertains also to these exposure pathways and to who's put in harm's way and then who has the greatest risk from being exposed to heat, to wildfire smoke, to changes in allergens, to mold exposures from flooded homes. And again, as with COVID, people and populations who have higher rates of underlying chronic conditions, those could be hypertension, diabetes, obesity, anxiety, and depression, are the people who are going to be most at risk from these climate change related exposures. Next slide, please. So what does this mean for healthcare systems? This is just a quick crosscut of what we were just talking about. So there are specific populations that are at greater risk. This may be because of life stage, like the elderly or children. It may be because of racial and social discrimination and other factors and conditions, recent immigration that may lead to people having less resources, low income. It may be people who have are living with disabilities from either accidents or conditions of birth, et cetera. But for each of these populations that our healthcare systems are ensuring quality care for, there are specific health outcomes that the healthcare systems need to be aware of, trends that are increasing exposures over time, and need to be also aware that we're seeing multiple threats at the same time. So the way that we have seen the vaccination and testing tents and makeshift facilities sometimes, or temporary facilities for COVID, be threatened by heat waves and hurricanes and floods. We have to be thinking in a more flexible manner about the delivery of healthcare systems in a setting where there are both threats to the people and also threats to operations and to the continuity of operations. Next slide, please. And I just wanted to share a resource. This is a dynamic interactive resource on the web pages of the New England Journal of Medicine. But I just thought it's one of the few places where you can see a really well thought out framework for how climate change interacts not just with human health, which is the left box there at the top, but with health systems and healthcare delivery. And so you can see their impacts of climate change on everything from the costs of services, the costs of utilities, to the utilization of those delivery systems because of either heat stress or other factors that are causing people to seek care in emergency rooms, to the disruptions of the systems because of power outages or flooding, as well as to the stresses on public health in general. And then on the bottom there, you can see the different modalities of how health systems can make themselves more resilient in the face of climate change related health threats. Next slide, please. So just to go back and to show some of the ways in which health equity and climate change intersect. What I'm going to show now are a series of maps and pictures that are highlighting some of the recent research that is linking systemic and long-standing racial discrimination as manifest by the creation of maps by the Homeowners Loan Corporation and then the National Association of Real Estate Boards, in which neighborhoods were characterized according to their financial risk. And there was a 4-color code where green was the lowest risk, red was the highest risk, and any neighborhoods that were demarcated in red would be, in general, deprived of access to low interest loans and sometimes to finance some loans at all. And historically, those areas that of cities that were already segregated, that already had the highest proportion of African Americans, people of color, recent immigrants, were uniformly those neighborhoods where those people were found were in the red zone. And recent research is demonstrating that that has profound implications for the social determinants of health and health disparities. So this is just a side-by-side of one of those homeowners loan corporation maps of the Fertile Crescent of New Orleans, dating back to the 1930s, next to the satellite image after the levees broke, just showing how the deprivation of financial resources is associated with the risk of inadequate infrastructure, in this case from flooding. Next slide, please. And this is just a sequence of several maps, and I'll go through them pretty quickly. This is one of the early maps from 1923, even before this was systematized into the nation's financial system, of a Richmond residential security map. And you can see that up to the northwest, to the left side, that's the green and blue zones, and off to the east and to the south, those are the red zones. Next slide, please. And this is a map showing that those zones are associated with the built environment. So this is a map of tree cover, and you can see on the left side there, the western side, their neighborhoods are more green. On the right, they've outlined those red line neighborhoods. And of course, now the center district doesn't have trees because that's all skyscrapers. But even to the east, you can see those eastern red line neighborhoods have much less green space and tree cover in this case compared to the west side. Next slide. This is also, of course, related to impervious surface. This is a map of impervious surface. On the left, you see that the zones look whiter. That's because they have less impervious surface. The darker gray on the right, more impervious surface, which means cement, which means trapping of heat and trapping of runoff and greater risk of flooding. Next slide, please. So if you have less tree cover, more concrete, you have higher summer temperatures, and that's what this map shows. The upper left western districts are blue, they're cooler. The red line districts are orange and tan, they are hotter. And so redlining that was put in place in 1923 is manifesting now in 2022 as urban heat islands and greater exposure to heat. And you can imagine greater exposure to transportation-related air pollution and other kinds of health threats as well. Next slide, please. So with that, let me pivot and discuss our office. Of course, our office was part of the mandates provided to the administration by the incoming presidency of Joseph Biden. There were 3 mandates given to the Department of Health and Human Services by Executive Order 14008, tackling the climate crisis at home and abroad. In addition to creating our office, we are also mandated to set up a new interagency working group to coordinate the federal agencies in protecting those most at risk from climate change and bringing a health equity lens to it, as well as a biennial healthcare system readiness advisory council of relevance to the health systems managers. Next slide, please. I'm sharing these quotes that were released at the launch of our office, which just took place a few months ago, August 31st, because they convey kind of the different dimensions of why I think this is a new day for climate change and health. Secretary Becerra talked about the moral imperative, and his quote is, "History will judge us for the actions we take to protect our world and our health from climate change." Admiral Levine, the HHS Assistant Secretary for Health, where the office is situated in her office, highlighted the health equity aspects of this and the relationship between the lessons learned from COVID-19 and the inequities faced throughout our nation by COVID-19, and how these are the same groups struggling the most with the effects of climate change on our health. And then Gina McCarthy, former administrator of the EPA and now the Biden National Climate Advisor, had something very important, which is recognizing that America's world-class medical community, in other words, our health sector, and bringing the health sector into the fight against climate change is a very significant event. And with the next slide, we'll talk about what's going on in that space. So the picture in this slide is a picture of Admiral Levine at the Conference of Parties, the 26th Conference of Parties meeting in Glasgow, the big international UN-sponsored climate change meeting where the Paris climate change protocol was derived from the Kyoto Protocol, etc. This 26th COP, I think, will go down as one of the most important events in the history of climate change and health, in part because of the event that was captured here, which was the creation of a COP26 health program, in which for the first time, health ministries around the world came to the COP and made commitments to that are highlighted on the bottom there, to resilient health systems and low carbon health systems. This was the first time the US had an official delegation from the Department of Health and Human Services. And I do think that this elevation of the health sector in this space of global climate policy will be transformative in mobilizing people's opinions and actions to address the climate crisis. And so I won't read them, but you can see the language that we put to what we were doing as the United States for resilient health systems and low carbon health systems, in particular on the low carbon health systems, pulling together the federal health systems, which already had a mandate, from the Biden administration's targets to reduce, to account for greenhouse gases and set in place reduction plans, and also to partnership with the private health sector of the United States to share best practices and to bring the levers of the federal government to bear, the incentives, the financing, and ultimately, as Secretary Becerra made clear, the use of regulatory authorities, if needed and as needed in the future, to harmonize the health sector of the United States in these goals. And we divide our work into those three priorities that you see there. The first being protecting the most vulnerable from the health impacts. The second, recognizing what we've been discussing in terms of social determinants of health and the power of climate actions to address the transportation infrastructure, the green space in our neighborhoods, and so to work with those sectors to address quality of life, social determinants of health, and address some of those root causes of health disparities to make people more resilient. And then the third priority area, the health sector resilience. Next slide, please. And to codify that federal health system decarbonization, after the COP in early December, a new executive order with this title, Catalyzing America's Clean Energy Economy Through Federal Sustainability, set very specific targets for buildings, for fleets, for our energy supplies, for the federal health system, for the federal government, which includes the federal health systems of the Department of Defense, of the Veterans Administration, and the Indian Health Service, the community health centers of HRSA, the clinical centers of NIH, et cetera, all need to comply with this executive order. And so this is the federal government really walking the walk as we try to move the nation towards these decarbonization goals. Next slide, please. I will go quickly through these, but just some of the details in terms of the steps that we're taking in our early life, just a few months old. On our priority one, we are working with items that are actually part of the Justice 40 agenda, like efforts to make the low-income household energy assistance program and also some of the Medicaid flexibility more available to people to be able to address heat stress and be able to help low-income populations with energy costs, with purchase of air conditioning units, is for people who are most at risk. And we're also working as an office to convene the power of all the agencies across the federal family to address extreme heat. We've stood up a new working group there, and then we have that interagency working group on vulnerable populations more broadly that we've been mandated to create. Next slide, please. In terms of the actions to reduce health disparities, we're engaged in a lot of conversations with CMS, with HRSA, with other parts of HHS about ways that the current efforts to really start to identify deficiencies in the social determinants of health. Deficiencies in the social determinants of health and their role in health disparities through things like Z codes, through bringing them into the role of health systems to address the upstream social determinants, to make sure that those social determinants associated with climate change, with built environments, with housing, and energy security, as well as food security, can start to get incorporated. And then ultimately to help build technical capacity to look at the health implications of infrastructure projects working across those sectors and those agencies dealing with transportation, housing, et cetera. Next slide, please. And then in the area of health sector resilience and decarbonization, our COP26 commitments were really the big move so far. And then, as mentioned, we're working with our federal health system partners to identify those early steps, the key levers we can take to move all of the health systems of the federal government, and then bringing our federal partners together with the private health sector, especially through a National Academy of Medicine initiative that's going on to identify the best practices and try to harmonize practices with the private health sector as well. Next slide, please. And as a piece of this, we are starting to work with our colleagues at CMS on gaining, walking down that path that it takes to get change in the policies, practices, support, and reimbursement policies of CMS, starting with this request for information. So this is a quote from a notice of proposed rulemaking. I think it's closing tomorrow. So if you have not yet seen it and had an opportunity to weigh in, please do. But we have language in there saying that the HHS wants to explore how exchanges and their constituent organizations can more fully prepare for the harmful impacts of climate change on their enrollees. And there's a lot of specifics behind that. Next slide, please. And next slide. So in summing up, I've listed some of the possible policy areas for exploration with the NIHCM, with those of you who are listening in. There's areas that we can shore up the resilience of health systems and communities. There's many different entities across the federal government that work on regional networks of hospitals of public health systems for preparedness. There's the preparedness of health systems and the policies through the emergency preparedness rule. We're looking at all of those things to make sure that there aren't gaps that people are falling through. We're looking at the flexibilities and innovation programs for supports to vulnerable beneficiaries, for housing, for energy security, looking at climate sensitive indicators into the measurement updates. We started with that RFI, and then looking in ways that we can not just say, well, these are the things you need to do, but to actually make it easy to do them by finding the financing and resources that we can, especially for those hospitals already strapped, especially for those systems caring for the most vulnerable, which tend to have the thinnest margins to start with, and also to find ways to give that technical assistance to make it easier for health systems to look at some of the decarbonization and resilience steps. On the decarbonization side, we're looking at evidence-based actions. Scopes 1 and 2 are what the hospitals have the most control over, 1 being the direct emissions of greenhouse gases, 2 being those associated with energy supplies. It's Scope 3 that's the bulk. Scope 3 are those associated with supply chains, and we're working very hard in a number of different ways to identify ways to bring our suppliers into the path of decarbonization and resilience as well. Many corporations, many leaders in that sector are already walking down that path very far. We're looking to come up with easy ways to do the greenhouse gas accounting and to be able to publicly share that through tracking tools, to increase the technical assistance, and looking at those ways that we can work on the financial incentives, again, to remove as many barriers as we can to the progress that we know we have to take to make the health sector one of the partners in addressing the climate crisis. Next slide, please. So with that, I'll close. I look forward to the discussion we're going to have. I especially look forward to the next couple of presentations, bringing kind of the real world perspective and making all this real. Please do visit us online at our website. We are going to be building that out over the coming months. We will and be sure to sign up for our listserv there, because that'll be our primary way of communicating what's going on, sending updates, alerts, and helping to build the resources for the whole community. Thank you very much, and I'll close there.
Thank you, Dr. Balbus, for your leadership on this issue. We look forward to continuing to hear about your work and exploring partnerships with the leaders on this webinar today.